The purpose of this presentation is to explain a new project that has been launched in Missouri to explore decision-making options for adults with developmental disabilities. The Medical Rights Workgroup has been convened by the American Academy of Developmental Medicine and Dentistry, Spectrum Institute, and the Alternatives to Guardianship Project. 3 of us are coordinating this project. My name is Thomas F. Coleman. I'm an attorney. Dr. Emily Johnson is a medical doctor, and Jennifer Hume is a disability services consultant. The work group will be holding its first meeting in January 2024. It will meet by Zoom once a month for 6 months, at which time a report will be released to share our findings and recommendations. The work group has 26 participants who represent various aspects of society. There are patients, supporters, medical providers, professional associations, academics, government regulators, rights advocates, and disability services providers. A wide range of perspectives will be included in our conversations, from self-advocates and family advocates to perspectives from medicine, dentistry, nursing, social work, psychiatry, state government agencies, public guardians, hospital administrators, legal services, and unfortunately, what's missing is perspective from the judicial branch. We tried repeatedly to have the judicial branch participate with this project, but we were unsuccessful. The primary purpose of the project is to identify ways to better protect the medical rights of adult patients with developmental disabilities, while at the same time respecting the legal and ethical duties of healthcare providers. The secondary purpose is to identify ways to better prepare youth who have developmental disabilities to transition into adulthood, a time when they will have the authority to make their own medical decisions with the level of support they choose. 2 documents were sent to work group members to read prior to our first meeting. The first is a memo about the basics of medical decision-making. The second is an article written for patients, families, and healthcare providers about medical decision-making rights. It was published in Helen magazine, which is the official publication of the American Academy on Developmental Medicine and Dentistry. Both of those articles are available online to members of the public. And the links are provided here for those articles. So the January meeting of the work group is going to be exploring 3 general areas: demographics, legal considerations, and ethical requirements, what I call the who and the what of medical decision-making rights. With respect to data on patients, there are 4.7 million adults who live in Missouri. About 217,000 or so have a cognitive disability. About 73,000 have a developmental disability. But only 30,000 or so of these individuals are living under a guardianship, only 14%. So we can see from this data that 86% of adults who have cognitive or developmental disabilities are making their own medical decisions without a guardianship. The lesson from this is that medical providers should not prejudge someone just because they have a cognitive or developmental disability. They may very well be able to make their own medical decisions with the level of support that they want or need to make informed decisions. Guardianships are generally not necessary. Now, this slide shows that about 1/3 of adults who are in a guardianship are having their medical decisions made by a public administrator. So public administrators are playing an important role in the lives of a significant number of adults with cognitive or developmental disabilities. And generally, they're doing the very best that they can, but they're underfunded and understaffed. So the average caseload for a public guardian is 90 adults. That just seems like, well, on the average nationally, it should be about 20 adults. So it's way over the national average or what's recommended. The public guardians often lack the resources to properly explore less restrictive options, such as a power of attorney or a supportive decision-making arrangement. This takes time and resources, and they don't have it. So unfortunately, less restrictive alternatives are not being considered in some or many cases when they should be. Also, due to inadequate resources, public guardians may not be petitioning to terminate a guardianship that's no longer necessary and to restore medical rights of individuals in a timely manner. And this chart and this data and information is based on a 2020 Missouri Public Guardianship Report. Families play an important role in the lives of adults with developmental disabilities. Most such adults live with their families. And these adults generally want assistance from parents or other family members when they interact with medical service providers. So medical providers should be aware that families are do play an important role in the lives of these individuals, and medical decision making is obviously a very important aspect of their lives. So providers should be working with parents and family members and with the patients to maximize the role of the family in providing help and support to the patient, of course, with the patient's consent. In terms of medical providers, we've got primary care physicians, psychiatrists, pediatricians, nurses, dentists, and so on that are interacting with patients who have developmental disabilities. There are about 15,000 medical and nursing students in the state and about 45,000 doctors, dentists, and nurses in Missouri, all of whom would benefit from receiving educational instruction about the medical rights of patients with cognitive or developmental disabilities and how to maximize those rights and at the same time complying with their legal and ethical duties. In terms of the legal considerations, several legal principles must be kept in mind by providers. The first is autonomy and consent. The common law recognizes the right of an individual to make their own medical decisions. And any adult 18 years of age or older is authorized by law in Missouri to consent to a medical procedure if they have the competence to enter into a contract. And some contracts are very simple, others are more complex. So we'll get into this more in the next slide. The law presumes every person to be of sound mind until the contrary is shown. And just because a person has a mental or developmental disability does not necessarily deprive such an adult of having the capacity to make a medical decision. So developmental disability does not equal incapacity. We have to dig deeper. The law says that the burden of proving lack of mental capacity to contract is on the party making that allegation. So if it's the medical provider that's saying, I don't think this person has capacity, the medical provider has the burden of coming up with evidence of incapacity, clear and convincing evidence, which means that there's a high probability that the person lacks capacity. And coming up with that evidence isn't just based on assumptions or prejudices, but it's got to be based on an actual assessment, competent assessment by a qualified individual. We'll get into that more in a future meeting about how to do this. The law says that capacity is not all or nothing proposition, that the person either has capacity to make all medical decisions or they lack capacity to make all medical decisions. It's not a global matter. It's a situation-specific matter. And the question is whether on the day the decision is made, did the person have sufficient mental capacity to understand the nature and effect of a particular transaction? So, did they have the capacity to make a medical appointment? Did they have the capacity to say yes to having an X-ray done? Some things are just so simple that almost everybody has capacity. And you get into other situations where there's going to be complicated surgeries with major risks. That's a different matter that can be looked at with more depth, but it's always situation specific. The same would hold true for capacity to execute a power of attorney. So also incapacity, anyone who's alleging incapacity has got to show that there's some harm that could come to this person from this medical decision. So simple decisions that carry no risk, the issue of incapacity doesn't even arise. With respect to powers of attorney, most people have the capacity to execute a medical power of attorney. All they need to know is, the patient needs to know, is there may be times when they can't make their own medical decisions due to lack of understanding or an inability to communicate. That's the first thing that they need to know. Two, that they want a particular person to have authority under those circumstances. Three, that by signing this document, they're giving that person authority. And four, that it's voluntary. There's no undue influence. They're doing this voluntarily, and that they can revoke it at any time. So those are the four considerations, and it doesn't take a lot of mental wherewithal in order to have the capacity to know these facts and to execute a valid power of attorney. Also, in terms of the Americans with Disabilities Act and other federal and state disability laws, the providers have a duty to help the person provide sufficient information in terms that the person will understand, to take as much time as is reasonably necessary to do that, to help them to execute a power of attorney or to make medical decisions or to have a supportive decision-making arrangement, which, by the way, the legislature has specified that alternatives to guardianship should be seriously explored and used when feasible, and that includes powers of attorney and supported decision-making arrangements. So down the road, we'll get, in another meeting, we'll get more into how the provider can comply with their duties under the ADA and other disability laws to assist patients and their families in using these arrangements. Next, there are ethical considerations for providers, especially doctors and dentists and nurses and so on, who have ethical duties in providing services. The four basic areas are autonomy, justice, beneficence, and non-malfeasance. The principle of autonomy says the provider should allow patients to make their own choices, either independently or with help from a chosen support person or through a chosen agent in a power of attorney. The ethical duty of justice requires providers to treat all patients fairly and with equality, avoid discrimination, don't act out of prejudice, and provide reasonable accommodations to help the person in the decision-making process. Beneficence is to do good to patients and for society. And part of that is making sure that you're properly educated to provide services to this particular special needs population. So more education may be necessary to comply with this ethical requirement. And finally is non-malfeasance, do no harm. And I think as an offshoot of that, providers should take appropriate action if there are signs of abuse or undue influence involving a patient with a developmental disability. So that's basically the nuts and bolts of the who and the what of medical decision making. It's much more detailed in the two documents that were provided for reading prior to this first meeting. Future meetings in February, March, April, May, and June will focus on other issues, and we'll build upon these basics and get more into the how to do things, how to prepare youth to assume the role of an adult, how to better educate medical practitioners and students on legal duties, ethical concerns, and best practices, how to improve the policies and programs of state and local government agencies, how to implement the new Health and Human Services non-discrimination rules that will soon be adopted. So in the meantime, we would encourage people, members of the work group and their colleagues and members of the public who are interested in these issues to visit the website of the Alternatives to Guardianship Project for more information and for more resources on these issues. And that can be found at alternativesToGuardianship.com. So thank you very much for your attention to this PowerPoint presentation, and look forward to meeting with all of the members of the work group, having conversations and collaborating to find areas of consensus, areas of concern, and how we can move forward to improve the situation for this patient population. Thank you so much. See you soon.